It is a delight for us to be here with you. And I just want to thank Cindy for taking the time to come out from New York and be with us to have this conversation. I think we're already learning a lot just from what we heard this morning. Cindy, you're a fascinating person.
Thanks.
Because you're leading a program area where you've done deep scientific work. And in talking with me just a moment ago, you described how you think as a scientist. And I think that's where I want to start. How has being a scientist affected your thinking about the role of philanthropy? Before we get into any of the work and what you're doing, let's talk about how you got there.
Thanks for that question, because I think it so shapes many of the ways in which I have gone about my work, but also in which I've followed on what others have built before me. And I think information helps us, even incomplete information, helps us move forward and identify where to put our energies, right? And so that is how it has affected. I see the world through questions. Everything to me is a question, for better or worse, because we don't always have an answer. But we always, as a scientist, I can always think of, well, what do we need to know to make a next step or to decide which direction do we go in especially when there are so many societal problems. And in medical research in particularly, where there are much larger sources of funding, right? And so as a philanthropy, we try to find what is our place, what is it that we can do here. So I think knowing how to approach, what questions to approach and what information to gather, and how do you parse out, how do I decide how much time do we as a team put into answering a question or not to find a way forward, I think that's how I think of my role as a scientist, in terms of questions.
Right. So let's turn for a moment to the work, and then we'll come back to the convergence of those worlds in a moment. But I want to acknowledge that in 2023, the FDA approved the first CRISPR-based cure for sickle cell, a disease that had been understood since the 50s, 1950s, for anybody who's wondering, and in a way illustrated some of the challenges that the medical research community continues to face in terms of equity and access issues. So before we get into that, I'm just curious to hear you talk about your foundation's role in bringing that breakthrough about.
Right. And that's an example where there's so many issues at play, right? There are many inequities. And I think talk about data and connecting with the communities that drive the work, right? So I think at the time, if many of you may know that in general, for developing a new drug, it's not only a time-consuming process, but it's a very expensive process. And so at the time, and this was before my time there, I actually managed a lot of the work that we supported, but the actual position of supporting this field preceded me. But we thought hard about, can we, as a relatively small foundation and player in medical research, have a transformative role in a disease that doesn't have any cures at the time, but bone marrow transplant is still, it was the only option if you had a match. And through talking to the community, through understanding technology, I think at the time was a big factor, where we saw that technologies that were being applied to cancer research, that were helping us understand genetics better, were not being applied to this field that was neglected. And so we did see an opportunity to play a role in bringing the community to a field that needed that insight, right? And to work with those that have been in the space for a long time to guide, well, what are the important research questions here? And we approached this with a very broad lens. We said, well, what are the questions we need to learn more about in sickle cell disease? And we supported all kinds of projects, anywhere from gene therapies, and at the time they were nascent, right? Like, how do we, they had been gene-based, gene-modifying approaches, such as with viruses and things like that. But CRISPR wasn't there yet, right? And so, but scientists were already going in that direction. And then we also supported projects that were trying to understand, how do we prevent cognitive damage from stroke and sickle cell disease. And so having that, similar to this room, having that mixture of different fields and ways of viewing the disease, we think was very helpful for researchers, especially those who were new to sickle cell disease. But fast forward, less, I think, than 10 years after we began funding, that it was just a technology, the moment in technology was right too, where our resources met technology. It became clear that there was a bigger opportunity in continuing to push for curative approaches. And our funding, it was the right place, right time, contributed to some of these fundamental knowledge that led to the development of what is now Casgevy. And I think I never thought, I was a program officer at the foundation at the time, that in my lifetime I would see a therapy develop, some insight move from the lab into a patient and really make such a difference. So we realized that there's so much more that went into that, right? That we provided some seed funding, but where it's just amazing to see the difference that it can make in someone's actual life.
Such a great example. I mean, I think it illustrates, it's the way you describe it, it's a 10-year overnight success, right? So, and part of the genius of what you did, aside from being right place, right time, was having prepared for that moment by putting different disciplines together, correct?
Right.
As you think about doing that to help address equity and access issues, because in this case, we're talking about a disease that afflicts a particular population that is under-researched and has received a lack of resources to address this problem. What lessons did you learn from the work in this area that help you think about addressing equity and access issues more broadly in other parts of our society?
That's a great question. So what have we learned? So many things. So one, in terms of collaboration, is very powerful, but doesn't happen on its own, right? You have, I think you have to bring the right people and create the right incentives, and those incentives don't always have to be huge, right? I mean, I think as somebody put at our table, making the space for those ideas to happen, or recognizing that. The second thing that I think to me is was something of learning, is that research doesn't just happen in the context of academia, right? That is so important to understand what is important what is on the other side, right? As a researcher, we tend to think of, well, we'll do this to help this disease or that disease, that other disease, but there are people there, right, on that side.
Right.
And is that something they want? I think that after, we've seen the approval of now a couple of new curative approaches, we have also seen patients say, well, sickle cell disease is part of who I am and my identity. Like, are you trying to remove part of my identity by giving me this new gene, And so it raises important questions, right? Or as researchers, we think this is a great cure, but we didn't think about how that affects fertility, for example, and fertility of a population that already has limited access to preservation of fertility to begin with, right? And so it does to me, I think some of the learning is that we need more perspectives as we approach a problem. It's not an issue that science alone can't solve, right? That you really need others to shape what is the outcome you're after. Is it really just a cure, or what else is there to it?
When I think about the traditional image that I as a non-scientist have of how science gets done, it sounds as though you're just describing a process that is much more iterative and in contact with community than the image I hold in my head of the lone researcher in a lab trying to chase down a theory. Is that part of Doris Duke's philosophy about changing the biomedical research enterprise?
So that's a great question. It hasn't been. I think that so I am a researcher, I used to work in a lab. And I think many of us who are, or I speak for myself, I suppose I can say, but when I came to the foundation, I've been there, my role has evolved over the last 12 years. But my approach is very much that of a lone researcher. If we support this great idea that you had here, then, 10 years from now, you will be leading a great lab and do great things that will help society. And I think, and now as I've learned more through being in philanthropy, and I realized, well, that's not the whole picture. Well, we helped you get a great career, but we still have these problems. And there are many other people who are trying to solve the same problem who researchers might see as competitors, right? And where the input of the community doesn't always come in. It's also made me think about how we support researchers who are at certain places, right? And have certain, we tend to favor more some research questions than others, where community hasn't always been part of, and where communities is an input from society, I guess is how I think, where that hasn't been the norm, right? And that is changing, right? So PCORI, for example, has really done a lot of work to understand how do we productively bring research and communities to identify the important questions and outcomes. And so it is something that I think is changing about our thinking at the Dorsey Foundation of what role can we have in approaching research questions in a more with more societal input, right? With that in context, because research is not alone cannot make change.
Well, thank you for that perspective. I'm sensitive to the fact that in your role, you're trying to tackle a range of inequities that you see in the field. What do you think are the priorities? I mean, when you go to work every day, what dragon are you going to slay next?
Exactly. That's a great question. So this is, it can, as we heard from the discussion this morning, there are many issues, right? And where do you put your energies, right? And I think as we evolve our thinking, something that I think a lot about is what are those places where our support, and not necessarily being dollars, but where we convene a table, where we have a discussion, where maybe we support advocacy. What are those opportunities where it's almost like a match, right? Like our input of energy is a match that starts a fire that fuels a whole car or a whole rocket ship. It's because as foundations, our dollars are small, right? So if we fill a gap, then we are stuck filling a gap in one place, and we're not really changing the overall condition. So I think about that a lot, of what is the bigger opportunity that could really transform a system, and who are those champions that can help us identify, well, what are those, right? And I heard some ideas here today of we can approach a model, but how do we make it, is the word sustainability, right? So where are those opportunities where we're not talking about a patch, but something that might be a heavier lift, or might be seen by others as your approach might be, it's like a crazy idea, right? Like we're doing some crazy ideas right now, but following some crazy ideas. But
well, now I got to ask you about that.
Yes. So I think I'm attracted also to difficult problems. So that, and maybe as a scientist, maybe scientists can relate to this here, that we want to find what's the right answer here, right? And that drives us, right? And so for example, one of the ideas that we're pursuing recently that came up actually in conversation today here is, how do we think about race and ethnicity in the context of research and health, and how that has led to inequities, right? Just how we communicate about the association of race with health outcomes. How does this shape our thinking and further stereotypes that are harmful for equitable clinical care? That's the idea, but what we're actually trying to do is, can we change research practice so that we are more race conscious, right? So that when I design an experiment and encounter race as information, I make best use of that information in social context, right? So that as a researcher, we don't further inequities, because there are examples where, sorry, this is abstract, let me know.
No, I think this is exactly on topic.
That we think there's evidence that as a research community, we make inferences about race and ethnicity that are really as if they were related to biology or outcomes in medicine, and or they're related to outcomes, but as if they were related to biology when they're not, right? They might be indicative of an exposure, but because of experience of race in this country, you have you're more likely to have a disease, for example, or have X or Y or Z. But the way in which research has used that information in some cases has not been rigorous, right? We make inferences, erroneous inferences about biology, but also we have incomplete data and we still make inferences about race and ethnicity. And that has gone unchecked, right? And there are tools of medicine that many of you probably use every day, anywhere from measuring kidney function or pulmonary function to interpreting neutrophil counts that have an element of race in them. And I've learned all of this and I find it fascinating because every day I learn something new. How we assess cognitive function is normed by race. And so that actually has implications for patient care, right? And so we are trying to bring light to that and to the research community to say what checks and balances can funders, not just nonprofit funders, but the NIH, others can have in place to make sure that as a research community, we follow rules that further equity.
Let's stay on this for just a moment longer, because as I was listening to you, I was reflecting on the kind of broken cultural moment that we're in, where discussions around race are suddenly volatile in a way that can make it difficult to discuss the applicability in various disciplines. And, I'm thinking philanthropy has been paying attention to a lot of cases around affirmative action, the Fearless Fund case, and, our ability to concentrate resources on particular populations. When you talk to people to help them understand why it's important to look at race as a factor in better research, what is the case you make to them?
It's about better science and better tools for medicine. I think it is, and for health. It is about giving the health treatment that everybody deserves and needs, right? Because what we see right now is because of how you look, because of how you may self-identify or others may identify you in terms of race, you may be getting differential treatment that doesn't further your own health, especially if you're Black or brown in America. And so it is a matter of healthcare and medicine and research serving people equally or equitably, I guess is right. Because right now we are, if I'm Black, and depending on the hospital I go to in the US, it might be underestimated how well my kidneys are functioning. And that may keep me from getting care for kidney function, right? And so it is a matter of health for Americans, especially those who have inexperienced unequal treatment for so long.
Thank you. I just wanted to draw that out because of how important I think it is to keep saying this, that the work you're doing, and that so many of the scientists we're privileged to fund, and so many of the frontline clinicians that we're privileged to fund as well are doing, is trying to be sensitive to the special communities and needs that they're serving. And if you're oblivious or blind to that, it ends up being bad for everyone. So I just appreciate you're really focusing on that. Let's talk for a moment about caregiving, yes. Because I know this is also an area you're focusing on. Yes. So can you tell us a little bit about what you're doing there?
Yes. So we are, of course, we similar to your foundation. So we are building a more creative, equitable, and sustainable future. So we think of all aspects equity. How does it intersect our areas of work? And for caregiving, I think something that we all experienced or saw was really very visible during the height of a pandemic is how unsupported caregiving affects our productivity as individuals in our professions, right? Or in any activity that we have. It's not the caregiving, it's the lack of support for caregiving, right? and that affects us. And how we saw this very acutely is that we supported physicians who also do research. These are people that at a minimum, they have already 2 jobs, right? They're doctors and they're researchers. And they're also people. And so what we knew before the pandemic is that women tend to fall out of and this was in the context of academic research, that women tended to fall out of the workforce at higher rates earlier in their career. Within, I think it was something like within the first 10 years of faculty appointment, 40% faculty fall out of the workforce, and many of those are women. And there are many factors, right? We don't fully understand, but we heard from many researchers that there was this another hat they wore is their caregivers, and that sometimes research had to be cut out of their activities because they had to show up to the clinic regardless. They were doctors. And if they had a sick parent or sick child that had a chronic illness, or, they had elderly parents, they also had to take those hours. And so research was the one thing that had to go. And so we thought, well, why don't we do an experiment? Here's again, our research hats of, can we prevent attrition of faculty from research careers by identifying who are caregivers and giving them additional support for research. So we give you a little bit of funds, and I mean, like enough to cover a technician for a year or 2, so that they could go on and be the humans, the caregivers they were at the time, and have their research continue. So we found that this is a way, and studied. We gave a grant to a researcher, Dr. Reshma Jagsi, who was then at the University of Michigan and has since moved to Emory, who studied gender equity in academic medicine. And she documented that this actually helps change the conversation at institutions, right? So it's not just addressing a need in the moment for a researcher, but it helps in the context of the institution change the conversation from you are not really committed to research to we understand you're a caregiver and you deserve more support so that we can continue to benefit from the science that you are capable of producing. So that's how we have been supporting caregiving.
It's a wonderful initiative. So thank you so much for demonstrating the value of that work. It leads me into the question of other ways in which philanthropy can make a difference. And obviously one of the notions with private philanthropy is we can invest in ways that are different from government funds and from business, where we can take risks over a longer period of time, et cetera, et cetera. Where do you think private philanthropy, or where do you wish private philanthropy would do more work in this space to genuinely promote community well-being?
Well, some of it are biased.
That's okay.
I'll preface it with that. To come back to your comment earlier, right, that there are areas where we can go without fear, right? Where we can really bridge different perspectives and try to find solutions. I think something that I wish we would do more of is recognize that research happens in different contexts, not just in academic settings, right? And this is something that we've heard here a lot today, that there's a lot of opportunity, but where the incentives are not there, where I think that it'll take many different players, not just philanthropy. But I think that what we as philanthropy can do is try to illuminate that there is this new frontier of innovation, that there is possibility. And maybe if the opportunity and possibilities aren't visible and clear, have those conversations of how do we illuminate what are the opportunities here? How essentially being the ones that bring awareness to the research communities and others who need to be involved to change our focus from sick care to healthy care, right? And working together. I mean, that's another thing that I wish we do more as philanthropy is seeing where those opportunities are, that we may do things differently, but where we have a common goal that we can elevate issues that are of societal importance together, right? Because I think that makes hopefully has bigger impact.
Well, I love your framing of a shift from sick care to healthy care. Mm-hmm. And that one of the ways of getting there is through this broader level of collaboration that philanthropy theory can help bring about. I'll confess, we have in this room with us a set of leaders who are bridging the worlds of being in community, providing care, and doing the seminal research that is driving progress forward nationally and globally on some of the most pressing issues of our medical research issues of our time. And I confess that when we first had the idea, someone had the idea of putting this group together, I thought, how's that going to work? So we don't always naturally lean into putting groups together, but why is this healthy? Why is this important for the sake of better medical research and also better care?
For many reasons. It is so important for many reasons. I think one of them is, well, we truly understand what are the hurdles, right? And where are the opportunities? So some of the conversations that I heard were, how do we make data more accessible, right? And yeah, I'm looking at you here, which are a table of how does the data really flow within a hospital and a health system, and what are the hurdles a researcher may have, for example. So one of those are very, very like in the weeds, right? So some of those opportunities. But I think some of the larger opportunities are also to begin to see that all of it is important, right? It's not just me understanding how a cell, regulates growth for cancer is important, but is how does that really how does the discovery make its way to the clinic? Or is that really as a researcher, I think it illuminates what are the real needs that clinicians have today, that maybe my efforts could be oriented, even if in a little way, and begin to be better informed more by what are the on the ground needs for clinicians, for example. So research that, I think understanding that there's different types of research that are needed to move health is not all about discovering the new pathway to develop a new drug, right, but that there are other problems that really need our intellectual curiosity to move them forward. I think that is so important for these spaces to illuminate what are other types of research questions that are also important and that we need to put our energies to. And I think for us as philanthropies is how do we elevate that as those ideas as some that need resources nationally, right? Because I think another conversation we've had is how do funding models help further those ideas or not help, right? So I think we can carry that voice of saying, how can we change the funding structures? And maybe that's, again, a difficult problem, but I don't think it's impossible.
Well, it's one we can actually maybe do something about.
Exactly.
So, in terms of bridging the worlds of community healthcare practitioners and medical researchers, what would you hope to encourage among the folks in this room and the larger community nationally in those worlds? What do you hope to see more of?
I hope to see more understanding that health is not a collection of disciplines, right? I think as research community, we may tend to see the problem only very narrowly through, I'm a sociologist, or I'm a biochemist, or and it's true that we bring that specialized knowledge, but at the end of the day, we need to focus on the humans, right? So we have mental health, right? Is it an issue of the brain, or is it environmental, or is it all? And how do we bring all of our abilities around the problem rather than around my own career or my own academic path or the field of X or Y or Z, right? So I wish we'd see more of that centering around what are somebody said on my table, the outcomes we want to see and the problem, and how do we bring all of our abilities to those.
So as you heard the conversation this morning among the leaders in this group about the challenges that they're facing and the opportunities that they see, you're looking at it from a national viewpoint where you talked with folks all around the country about this. Was there anything that stood out to you in this conversation as especially emblematic of what everybody is talking about? And was there anything that stood out to you as unique to San Diego?
It's a good question. And I have to say, we're starting to have this conversation. So we hope that others will join for later in the fall. But from what I hear I hear a lot of is the focus on communities as the source of the information for what is important and what is important now. I think that is a common thread of what I have heard. And what is unique to San Diego, I think that it's just all the recognition that, well, maybe this is, I have to say, I'm coming from outside of San Diego. So, the recognition that there are communities already here and in this room that could identify together what is it that's needed. I think that is something that, and there are unique problems that we heard about related to the nearness to the border, that we're seeing this crisis of immigration, right? Climate crisis. Right. I think that's something that I heard here today.
Well, this seems like an opportune moment to turn to San Diego for some questions. What would you all like to hear from Cindy or from me?
Thank you so much for your insights. I was curious how you go about engaging politicians and policymakers. I just got back from a trip to Capitol Hill for a Congressional Life Sciences demonstration, and I found it enlightening. And very interestingly, I saw a lot of young people working. The staffers in DC are very young people who are very eager to learn more about science. They have mostly political science backgrounds. But I found that very valuable to try and explain the science to them, and they were very eager to learn it. So I wonder how you engage.
Thanks for bringing that up. So I'm a scientist, so I am very much in a learning curve on that, and I think it's something that philanthropy could do more of, engage with. And of course, we have some limitations, but I don't think that we have this entirely exclusive. We have to find ways to interact with policymakers. But I think it's something we need more of. And what we need more of is also those of you who are doing the work, because I think, I can say it from my, Fifth Avenue office, where I read about all the work that you do, but where the direct experience is so important to put it all into context. We have been talking a lot about at the foundation about national funding for health and how that flows and what are the cultural barriers to changing that. And I think that we need examples, right? What does that look like? What does a different funding ecosystem look like? And what are the real challenges, right? What we heard here is, we can embed researchers into federally qualified health centers, but then the funding is gone. So those are such tangible examples that I think we need more ears to hear about. And so we invest quite a bit more recently in communications. We're very keenly aware of who could hear what is the message that we're trying to spread, and who do we need to engage. So we do engage more in communications driven and marketing and influence type of strategies.
I think that's such an important point, because sometimes in philanthropy and I think in various disciplines, we make an assumption that, once we know something, everybody will just do it, right?
Right.
And it's the last thing that happens. What we actually have to figure out is, when we know something, we have to collect the data and we have to verify what's true. But then we have to figure out how to tell that story so that it's compelling in a way that politicians have to pay attention to, and others as well. So thank you for that question.
My name's Jimmy Figueroa, and I'm with TrueCare. I have a question about the development of the sickle cell treatment and the implementation at the community level with our direct service providers. How has that process gone? What have you learned? I know you mentioned a little bit about some of the challenges that were not expected at the time. And is it affordable? Is the treatment affordable for our communities?
Yeah, so those are good questions. And an example of how I think different players interact with the issue, different points. And, where most of our energies went to were into developing and contributing research dollars to develop that treatment, but where there are real challenges in access, I think the cost is estimated something like $1 million or something like that. It's you have to essentially get a bone marrow transplant plus the transfer of edited cells, right? And it is something that is getting a lot of thought, I think, by people who know a lot about these. One example is the Innovative Genomics, IGI, the Innovative Genomics Institute, I think, which is just north of here at UC Berkeley, headed by Jennifer Doudna, who was one of the discoverers of CRISPR-Cas9. And as a scientist, I think this is just such a great example of how this group is thinking not just about how do we develop therapies, but what models can we build for commercialization that take into account access. Because right now you have to go to a specialized center to get, my understanding is, to get this therapy. And it is not accessible to everyone, right? It's because of cost, we have to, insurance comes into play. So there are organizations that are doing a lot around that. The American Society of Hematology has been looking at models for how to make this more accessible. And it is an example of just having the cure wasn't enough, right? It isn't enough to just have that.
Other questions? So much animated discussion. There's got to be a couple here.
Just curious, as you guys choose what's important or what questions to tackle, can you shed a little bit of light on that process? And it's like, who do you include in those conversations? Yeah, because I think that's where you guys have a lot of power of who you bring to the table. So I was curious if you could speak to that.
Agreed, and that's a very good question, because we might just look at what's in front of us, right, or what's in front of my computer, I guess I should say, or what our own interests are, or our own biases, and I think some of that growth process in philanthropy as a scientist is seeking out different perspectives and knowing where to engage in making sure that we're not just listening to the same group, right? So something that is somewhat new to us is when we're exploring a new sort of frontier, sometimes in this case, the intersection of research and care, we're doing it publicly. So we are setting out, and I'll be happy to share that, and maybe you can distribute it to this group, a request for proposals where we're really trying to listen, in conversations like this, what are the important questions? And we started with the thought of do we share this with academic institutions? And as we hear more of these conversations, that doesn't feel right? I think it's on us to seek out different perspectives, and it's tricky.
What I am fascinated by, which is the use of race and ethnicity in clinical algorithms, since I work on a project that's essentially an implementation science project with all the clinical groups and FQHCs here in San Diego County about heart attack and stroke prevention. And the number one tool we have in our toolkit is the ASCV, what we call the ASCVD risk calculator, which for those of you who don't know, calculates your 10-year risk of having a heart attack and stroke. It is meant to be used at a population health level. And one of the factors that goes into the little calculator, you can all download the app and see what your own 10-year risk score is, your race. Mm-hmm. And there's been a little debate about that, about whether or not it's age, sex, race, and then like your cholesterol, your blood pressure, et cetera. And does race belong in there or not? And I'm really, really curious about that and your perspectives, because we now know that all of a sudden American Heart Association is changing their mind maybe and saying race doesn't belong in there. And how do we think about race in clinical decision making? I think that's a really fascinating area where there is a bridge very directly between the work you're doing and clinical care. So I'm fascinated.
Yes, and it's something very important you touched on there. Many things is an organization that sets standards of practice, of how that is perceived, right? They changed their mind, but I think that how we view this is science evolves, right? And science exists in the context of its time. And so at the time, maybe that was the best available information we had. But now we know that categorizing people, and often is in like 4 categories, right? You're white, you're black, you're Asian, what is the other? I don't know, right? Is that really a way to categorize human diversity? It's imperfect, right? At the time, maybe he gave us some information that we thought would make it easier for a clinician to assess our 10-year risk of heart disease. But now we know that that's not the full picture, right? And so we also know that how we incorporate race, as I mentioned earlier, can further stereotypes and can further misconceptions about health and illness. And at worst, it can actually change the medical recommendation for worse for the patient. And so I think this is an example where it's complex, right? Where the factoring in of race was being made to account for a possible higher risk of disease in certain groups, racially categorized groups. But there are other examples where there's no justification for that, and where the factoring in of race can underestimate your likelihood of having an illness. And that's when we get into trouble, right? Where the consideration of race was not helpful and in fact is harmful.
Hello, my name is Angelina Renteria. I'm with Indian Health Council, and I'm so appreciative that you brought that up and for the additional question here. And I would like to make a comment and then a question in terms of research, race-based research, and the impact in tribal communities, for example. And as a clinician, the interesting way to navigate that information, especially if it's not fully understood by a community member, for example, in Native communities, we are one of the communities with the highest prevalence of, and I'm not going to name all of the things, but diabetes, obesity, substance use, domestic violence, and the list just continues. And so in creating an environment where we're advocating for one's health and almost sort of trying to balance out what the community hears about themselves, where they have now this belief that I'm doomed. And there's this really fatalistic mentality that no matter what I do, the likelihood of me, dying from obesity, CKD, again, the list goes on. It's a unique dance of how do we inspire staying ahead of the statistic. And for those that are really making an effort to make sure that we steer clear of all of these things that we're told are preventable, is there an impact there? Now we have additional stressors. I'm more likely to have all of these things happen in my family because of my race. I would really love to know, is there research that's studying the impact of these things? And for those that are actively pursuing and trying to, break the cycle of, I'd love to hear more, are there opportunities to study this? Because we are hearing from our tribal communities who are trying so hard to get ahead of the statistic, and the stress related, you can clearly hear and feel it from those community members. It's there, it's prevalent. I don't know if I asked my question clearly, but
I really appreciate your expanding on how an inference translates into what is interpreted and heard by a community, right? And this is what we're hoping that we can get to a point where the research community we all do a better job, right? Of how do we, just because you have an observation, it's a real observation, but it doesn't determine, it's not causal, right? It's not because of your race, it is because of what your experience of race has exposed you to, right? And so I think reframing that is so important. There was a recent paper of researchers who looked at a brain bank of African-American donors in the Maryland area. And they were trying to study the signaling in the brain, and this is post-mortem, right? And they had disease like cognitive, degenerative diseases like Alzheimer's and so on. Is it different than a brain that didn't have, from a person who had that disease? And a natural conclusion in another times would have been being if because you're African American, you're XY, you see that there is this association with race. But I think knowing better now, understanding the interplay of genetic, molecular, signaling and exposure, because of a racial group. You know, the conclusions are different, and how that was communicated of the exposures, which are preventable, have resulted in this observation in this particular cohort. And so to your point, yeah, so I think we can do better about communicating, and that is not causal, right? I think this is what we need to break through of saying it's not, it is exposures that you have had as a community and that are preventable, right? That hopefully is not, yeah.
All right, I think we have time for one more.
Thank you. My name is Roselle Mindo from University of San Diego. There's a lot of talks about artificial intelligence. Do you see that artificial intelligence as a tool that we can use to bridge health equity?
Oh, you're going to kick that one over to me. Yeah. I do, based on what I'm hearing about the AI tools that are under development in the healthcare space, that they are able, for example, to get past some of the cognitive biases that humans bring. So they're an additional tool for practitioners to see past what may be their own unseen biases, and that may address some of these issues around race-specific treatments and their applicability. And so I think it's hopeful in that respect. The downside is that we've also seen with AI that the tools are only as good as they're trained to be, and I think getting the bias out of the machine is going to be an ongoing challenge for this work. But I do think it actually has great promise in that regard. Would you agree?
I very much agree. And I think especially with biases, I think this is a community that is thinking of that and equity from the start, that there are groups that are thinking of the ethical implications and how to get ahead of it, so that we don't find ourselves with the problem we have with these other clinical tools where then they're embedded in medicine and just causing trouble. Yeah.
So on that hopeful note, I'm going to ask you a final question, which is how you see the arena of philanthropic funding for medical research and caregiving evolving over the next decade. What does Doris Duke think is the art of the possible over the next decade?
Well, we really think we need to work together. So I imagine in 10 years, philanthropy will look different, where we are moving beyond the individual missions to our common shared understanding of problems and applying our missions to common ground, right? Where we have moved beyond this perennial discussion of, do we need research A or research B? No, we need it all. And how do we really put our energies into furthering research that's important and elevate the prestige of that, which is not currently considered what is going to give you a Nobel Prize, right? I hope that in 10 years we have chipped away at that, of what is prestigious research to what is important research to pursue.
I think that's a beautiful vision. So on that note, Cindy Escobar Alvarez, thank you so much for being here for this conversation and contributing so much. And to our leaders in the room as well, thank you for being part of the conversation.
Thank you.